My name is Gregory Vidal. I'm a breast medical oncologist at the West Cancer Center and Research Institute in Memphis, Tennessee. I direct clinical research. I'm also lead the breast program and an associate professor at the University of Tennessee Health Sciences Center. And with me is Dr. Erika Hamilton, who will introduce herself.
Hi, Dr. Erika Hamilton. I'm the Director of Breast Cancer Research and the Chair of the Breast Executive Committee at Sarah Cannon Research Institute based in Nashville, Tennessee. Happy to join you today.
Thank you. So, we're at ESMO 2025, lots of breaking data. Really good year for breast this year.
Really good year for breast.
So, we want to start discussing DB05 and DB11. Familiar with those?
Yes, I top of the list of that really good data for breast this year.
Yes. So, thinking about the data that we saw, DB05 and DB11, let's just jump into it. What gaps do these address? And how do you think it will change the landscape of HER2 positive breast cancer?
Yeah, so maybe I'll answer that by talking kind of the gaps it addresses and then briefly just go through the data. We've had Trastuzumab Deruxtecan in the metastatic setting, probably the best drug and efficacy we've seen in long time,
at least
right?
in my career.
Yeah, exactly. And we're old. No, I'm kidding. I think the gap really is that we didn't have this agent in the curative setting. Mm-hmm. And we really don't want to have people relapse and have to live with metastatic disease. Really getting our most efficacious drugs up into the curative setting is important. We want to cure more patients ultimately. The differences between DB-11 and DB-05, and it's kind of fun that they reported at the same meeting, to be honest. DB-11 was a neoadjuvant approach, and so you essentially got 4 cycles of T-DXd, and then you got 4 cycles of taxane with Trastuzumab, Pertuzumab, or 12 weeks, 4 cycles, however you want to say it. And then in DB-05, it was adjuvant, so a la Catherine design, where you got 14 cycles of Trastuzumab Deruxtecan for nodal residual disease. So a little bit higher risk than the actual Catherine trial that was any residual disease, but nodal residual disease or unresectable.
Yeah. What about the control arms for those studies?
Yeah. So in the DB11, it was AC with THP. Yeah. So I think that's the controversial. We've been ahead and kicked it off. That's still the standard of care in most places in Europe, but in the United States, I think we really tend to use TCHP. So controversial in the fact that I think we think TCHP is better tolerated. We don't think it's more efficacious than AC to THP. We don't think that's an inferior control arm. It's just not our preference to give anthracycline in patients that are HER2 positive.
Right, especially the cardiac risk associated with it. I am going to ask about the arm that we saw a little bit about, which is the T-DXd only arm, the 8 cycles of that. What is your impression of that?
Well, surprising, right? I think it makes a lot of us ask the question why, and that arm that you speak of is the 8 cycles of Trastuzumab Deruxtecan kind of without that switch strategy. Yeah. We were told that was closed early. On one hand, if you think if 4 cycles of T-DXd is good, doesn't 8 have to be better? And apparently that's not the case, and I think we can all kind of imagine reasons or things that could have contributed. But I think at the end of the day, really impressive data with improvement in PCR rate with the T-DXd combo, and we didn't have to do it with anthracycline.
We did not have to do anthracycline. That's really, really good. And we've been sort of stressing reduction in chemotherapy. We saw some of that at ASCO with just TPH. Primary endpoint on this study was pathology complete response. We really don't have event-free survival yet, which is still we're waiting for. DB05 control arm.
Control arm was Catherine, so adjuvant TDM1, 14 cycles of one, 14 cycles of the other, both given IV every 3 weeks. Very, very even.
Very even. Will you use 11 going into 5, or have a preference for one or the other?
I think that is the billion-dollar question these days. You know, I may have a less popular opinion on that. I think, honestly,
That's the fun part.
either would be a win for patients, right? I mean, I definitely want to use one of them in the curative setting. So that's the good news. I've heard some people say, I'm really going to reserve this for patients that have residual disease, a la DB-05. Some patients are going to have a PCR. Some patients are going to do well anyway. I'm going to kind of salvage with Trastuzumab Deruxtecan, which I think is a valid strategy. But I was really compelled by DB-11, actually. And I thought it was really attractive that the ILD rates were really low in 11, 5%, no fatal cases.
Which is important.
Right. And then, you know, conversely, certainly DB-05 was tolerable, et cetera, but there were some fatal cases. And the ILD was above 10%, so more along the lines of what we expect, right? So part of
increased exposure.
Exactly.
14
versus 4, right?
Yeah.
So, you know, I think in the breast cancer world, you know, especially in the curative setting, we don't save the best, right? I really want to get patients to a PCR. Now, you know, maybe people with a little bit less disease or something, we could kind of get in the debate of that. But somebody that I think really has high-risk disease, I think I'm leaning a little bit towards 11. What about you?
So I think the difference here is, one, when the 5-way, you can give what is standard of care in the U.S., Taxotere, carboplatin, Perjeta, Herceptin, up front, and then DB05 later. The issue becomes the patients who don't get past CR on DB11 and they have a lot of disease, then I think, have to consider anthracycline for that patient.
I do, yeah.
And then possibly even TDM1 after. So you're potentially giving a lot more therapy. So I see both arguments, but there is almost, 60, 70% of patients, was it 80%? What is past CR rates on 11? Was it 67, 68%? 67%, yeah. So potentially 67%, you don't even have to worry about that. So that's the argument here. I fall with you, though.
Okay.
I was really impressed with the behavior of just 4 T-DXd, and I will lean more towards that, but I would have to also consider maybe in the ER-positive space where you don't think they're going to get as much PCR.
That's a valid point.
That maybe we'll take the other route. All right. Anything else about DB05, DB11 that you want to address?
No, I mean, I think, you know, overall, we've just gotten really comfortable with Trastuzumab Deruxtecan.
Yeah.
You know, I mean, I feel like when it first came out, we kind of didn't know how to manage the ILD as well. The nausea was a bit of a problem. I mean, I think most doctors have gotten really comfortable with the nausea. We've got a lot of tricks up our sleeve. I don't have patients that are really struggling with nausea on Trastuzumab Deruxtecan.
Patient population is still a heavy Asian population in those studies. Does that concern you versus the Western?
I mean, you know, no. I mean, I think they did have U.S. representation, you know, as good as we can. You know, these are global studies. They're going to be enrolled everywhere. And Asia's just beating us in enrollment these days, aren't they?
Oh, isn't yes, they are. And that's needed. All right. So transition to HER2-low, ultra-low?
Sure, absolutely.
All right. In that particular space, HER2 ultra-low, first of all, how do you identify ultra-low at your practice?
Yeah, so I'm lucky. My pathologist gives it to us. So that's standard right now, is that they'll give on an IHC 3+, 2+, 1+, 0 with staining or 0 without staining. So that's the wording they use.
Yeah.
But highly variable from institution to institution. Some people aren't getting it without asking. You know, it's not an automatic thing. They have to ask and go back to get it. So lucky that I get it, but I definitely think that that's a change that has to happen medical oncology in conjunction with our pathologist.
So much like you, we're fortunate we have our pathology. The door is pretty close to my office, and they do report ultra-low, low in our reports as an addendum of the report. The question becomes the patients who've already biopsied, they've already have their report. You're not going to would you do a biopsy to get ultra-low?
I would if I had to, but you actually can just request a reread, and they'll go back and look at it. And now if I don't get an answer I like, I might think about doing a biopsy, Greg.
I mean, especially if you think the patient might benefit from it.
Right.
Yeah. All right. How did that change the landscape of hormone receptor positive disease for patients who've exhausted the anti-hormonal therapy?
Yeah, I mean, I think, functionally we kind of continue endocrine therapies as long as we think patients are benefiting. Once we think patients have endocrine resistant disease, that's when we're thinking about moving to cytotoxics, chemotherapy, or ADCs, right? We have multiple ADCs in breast cancer. I still feel slightly proud that we're still leading the ADC landscape and all the other tumors.
Tumor types, yeah.
So, we now have 2 FDA approved, TROP2, right? We have HER2. And, the thing about the HER2 and HER2-low is, and ultra-low, is that we see it disproportionately in HR positive compared to triple negative, right? So about a double the amount of patients that are HR positive will have it. And so for me, really, Trastuzumab Deruxtecan is my go-to ADC for HR positive. We can get in a whole debate about triple negative, which I don't think is in the scope here. But, I think compelling data, especially with DB06 now.
Yep.
DB06 looking at a little bit of, a different population than our HER2-low trial. It also looked at, the 0 with some staining, but also moved it up into that first line spot. And I think that's a little bit controversial. Are you going to give it first line or not?
So tell me about this.
Yeah.
So there is some data out there, reports out there that the academicians are not using it up front as much as the community. And you are, well, much like me, I feel like I'm quasi-academic, and I feel
I
like you're
jump
close,
across the
you're
line
close to
depending
that too.
on how I
Yeah,
feel.
Yeah. What do you feel about that?
I see it both ways, and honestly, I do both for patients. I understand the attractiveness of a capecitabine in HR-positive disease.
Yeah.
It's oral. It doesn't have hair loss. This is completely inappropriate, but I call it the gateway drug to chemo. And then on the other hand, there's a clear benefit with DB06.
Yeah.
So sometimes kind of that patient in front of me, how old they are, what's the burden of disease, how quickly are they progressing, are they in trouble in the liver? That'll influence me. But sometimes I have my patients kind of saying, no, I want capecitabine first.
Yeah, because they're coming off mainly all oral type regimen.
Right.
It's just very comfortable to continue them to oral, and they're asking whether they're oral types. DB06, the only issue is really they had only about 3% bone-only disease.
Right.
And for that population that I've always felt respond well to capecitabine, I'm really leaning towards cape for those patients. The other, I guess, I tend to use when I need to for patients that have concerning visceral involvements. I would use T-DXd. I still do go for a little cape. Do you ever use a taxane instead of T-DXd?
No.
So once you're going from thinking IV, it's
Right.
T-DXd.
Absolutely.
Yeah, and so I feel that way too. But I'm also comforted by the DB04 data that I could definitely rescue any patients that I
Exactly.
didn't in that space.
Although, we say that all the time, that we can rescue patients or they could get it in the next line, but I'm always horrified looking at the data of how many patients drop out from line to line of therapy.
Yes.
It's about 20%, and I'm like, no, like, that does not happen in my practice.
Have you looked at it?
Oh, I mean, there's no way. It just doesn't. But I mean, I think what happens is that, people can die of other reasons. They have a complication, and so you don't really think that they died of their cancer. But I mean, that's a statistic. I mean, it's multiple places in the literature that you shouldn't count on that next line of therapy because your patient may not get there.
Maybe it's everybody else but you. I haven't looked, but I feel the same way about my
I don't
data
have a
set.
big enough ego to believe that, Greg.
Like even in the triple negative space, I quote the same data too.
Yeah.
Like 50% dropout from first line. But I'm like, in my practice, is it really 50%?
But I mean, I think there is somewhat of a bias of who comes to a clinical trial site, et cetera, compared to, other places maybe too.
Yeah. ILD concerns in that population?
Yeah,
Hormone receptor positive?
I think you've got to be concerned with ILD when you use Trastuzumab Deruxtecan. I mean, that's just wise and smart, and we need to be concerned. But I think we're doing much better. Knock on wood, I've never had a fatal case of ILD, so I'm going to try to keep that up. I think really the important point is to educate, community oncologists that may be seeing all tumor types, that this ILD is different than what we think of as ILD with like a checkpoint inhibitor, where you don't really care much until it's grade 3, and you're certainly not holding the drug at grade 1, right? So I think really just being vigilant around recognizing that it can happen. It's more common to happen in that first year, less common to happen after the first year. But I'll have to say, I only had one grade 3 ILD, and it wasn't in the first year. So I'm vigilant about ILD always. I think it lets us know to not space out our scans too much on Trastuzumab Deruxtecan. I scan every 9 weeks, every 3 cycles.
Okay, makes sense. Especially, I do also, for patients I'm concerned about, I would probably go sooner, especially if there was a question of ILD coming into it. I've had patients who were questionable ILD on Abema.
Oh, okay.
And it's resolved. That patient, I am doing a 6-week scan just to make sure, because again, it's not really fully flushed out.
Yeah, sometimes it's hard to get the CT scans through at a more frequent than every 8 weeks unless you have a good reason. Now, if anybody has shortness of breath or any symptoms, you certainly can get a CT scan at that point. But
yes, so that it's very concerned. The other important point is, and I think the French group had a presentation last year, ESMO, about what it can look like on a scan, and it brought to my mind that ILD can look like pneumonia. And so you always have to keep in your mind, if this patient is on T-DXd, and I think the one patient I've lost with that is she had really, the imaging looked like it's a consolidation, like it's pneumonia, and she went to a hospital that really wasn't affiliated with us.
Right.
And the reports we were getting when I speak to the doctor, she has pneumonia and she's on high antibiotics. And it just turns out she wasn't responding. And it was a little bit too late to try to rescue her because of that.
yeah,
All right.
low threshold to think of steroids.
Low threshold. And we think of HER2 as the new Herceptin.
It's way better than Herceptin.
Well, probably, what about the impact?
Yes, definitely think it's had a transformative impact in not only HER2 positive breast cancer, but also low, frankly. I don't think of it as Herceptin, though, no.
No. I mean, in terms of toxicity, for one, it's very different. But the impact that it's had, you remember, I wasn't in oncology at the time when the Herceptin data came out, but it changed a tumor type that was the most deadly into probably the best outcome now when we think of our patient population. So it has an
more
impact.
transformative in a lot of ways because there's so many more patients that will get Trastuzumab Deruxtecan than that 15% that was eligible for Trastuzumab, right?
And maybe now that we have DB-11 and DB-05, we have less patients getting it later on in the metastatic setting.
Yeah.
So it's all good. I think we highly recommend it. DB-04, I think you sort of suggested that for the patients you give CAPE up front.
I mean, not routinely. I mean, I would say I'm pretty split of whether I give Trastuzumab Deruxtecan up front or CAPE up front just based on that individual patient. Age, characteristics, rate of progression, their preferences, whether they're willing to potentially lose their hair, whether they're willing to get a port, that type of thing.
Yeah. DB-04, I'll always remember the standing ovation that it got, and it wasn't a forced one. There's some forced standing ovation that happens with new data. Now everybody's trying to mirror the DB-04, but it was genuine. Like it just, everybody recognized how it changes what we're going to do.
Part of it, I think the data of DB-03 was just as fantastic, frankly, as DB-04. But part of it was that it was so paradigm shifting for us, right? I mean, it's not that we never tested Trastuzumab in a low. I mean, we did. It's just those curves were on top of each other, right? And so the idea that you could get that level of benefit in a cancer with low HER2 expression when it's a HER2 targeted drug, I mean, I think just kind of blew our minds, frankly, right?
Yeah. let's talk. I'm going to go back to DB05 a little bit. Heterogeneity.
We're really just trying to confuse everyone about the numbers here.
I know, yeah. And DB05, I'll remind everybody who's listening to this, is T-DXd versus T-DM1 in patients with residual disease after neoadjuvant chemotherapy.
And not just residual disease, residual nodal disease.
Disease, a high-risk population, not everybody. Thank you for correcting that. Heterogeneity of disease. I know there's some data which suggests T-DM1 may not be as active in tumors that are very heterogeneous. We have not seen that level of data yet from 05, but do you anticipate there to be any issues with heterogeneity?
No, in fact, I actually feel more comfortable giving Trastuzumab Deruxtecan in heterogeneity than I do T-DM1, right? I mean, we know that T-DM1, you really need a high HER2 expression to respond, yet in Catherine, even the people that had converted to HER2 negative at the time of surgery still benefited from giving T-DM1. So I actually feel even more comfortable with Trastuzumab Deruxtecan now that we've got it for 2+, 1+, and now to 0 with some staining, that's going to be a good strategy.
So does that change your mind about DB05?
Oh. No.
Does it influence your 2+ HER2 positive that barely meets ratio of positivity?
Yeah.
Are you thinking then T-DXd, is that going to influence it versus
Maybe,
a 3+
actually.
expression?
Yeah, maybe.
Yeah. See,
And the ER positives,
and the ER
right? I mean,
positives,
they're going to
you have
have
to-
a lower PCR rate
Right.
a little bit, right?
Yeah, which means that you're going to have to force to think of giving them AC.
I know.
That is
I know.
going to be interesting. So HER2 scoring and the current assay that we use was really not developed or designed to check for ultra low or low. It really was validated in the 3+, really meant for, designed for 3+. Do you think we need another test
I mean,
to help that?
I think in an ideal world, yes, right? I mean, the question, and this is, provocative, the question is there really a population in breast that doesn't benefit from Trastuzumab Deruxtecan, right? I mean, I don't know. It's probably small. And the problem is that we have such heterogeneity. When we biopsy somebody, we're only looking at one tiny spot within one lesion, and we don't know what's going on in the rest of the body, right? It's not like it's circulating tumor DNA where we can accurately get, a HER2 status on every, spot, every area of the tumor, right? So, I mean, I do think that this is actually one of the opportunities for AI, to use a buzzword. But, there's a lot of AI strategies looking...
digital slide reading using AI? Okay.
And different ways of capturing HER2 that's not just IHC, right?
All right.
More quantitative methods instead of qualitative.
I often say, theoretically, there really shouldn't be a HER2 negative cell because that HER2 pathway and protein is important for normal cell function.
Right.
So it's really about the assay and its ability to really detect low expression of HER2. So we should be able to have activity. In retrospect, I think if you're designing a T-DXd study, you're probably using all comers.
Yeah, I actually in my clinic have told my NPs that I don't want to hear HER2 negative anymore. You're HER2 positive, you're HER2 low, you're HER2 ultra low, or you're HER2 null. There's not a negative. It doesn't mean anything anymore.
Yeah, and so I think ultimately that's where we should move with new HER2 testing. I didn't realize there was a southern versus northern approach.
I don't know if that's true. Might be a sweeping generalization.
It is definitely a sweeping generalization. But let's
And we would both classify ourselves as southern, right?
southern, yeah. So let's talk about sequencing, ADC. There is data. It's all retrospective. No prospective data, and we're making a lot of decisions about ADC after ADC. What do we currently know about sequencing ADCs?
What we currently know is that in general, you get less benefit from the second ADC. And we're specifically talking about topo after topo. Okay, we don't have any that are non-topo ADCs, so that's something that could change. If we had novel target, novel payload, that may be a game changer, right? But so, with our TROP2 ADC and our HER2 ADC, the question is, do you feel comfortable giving them right after each other? Should you do sandwich chemo? Do you think that second ADC is not going to help? And I think that's where the debate comes in a little bit.
And so there was some data, and I guess that's why there's the northern versus southern conversation coming out of the northern group that suggests that regular chemotherapy in between ADCs is as good as an ADC, except in the population that came off ADC 1 for toxicity and not. Do you ever do that?
I do. I have to say that I tend to use clinical trials there a little bit more frequently.
Yeah.
I'm not opposed to using ADC after ADC. So, the data that we have right now is, yes, that second ADC is going to give you less benefit. Guess what? That's the same with chemo. Each line of therapy, people do exceedingly worse in terms of PFS. So we shouldn't be surprised about that. We know that both ADCs beat chemo. And so unless we really have data that chemo is better than that second ADC, I think kind of worst case scenario, honestly, they're probably about equal. And they're a little bit easier to tolerate.
There's a cost difference.
There's a cost difference.
To the system for most. T-DXd in the hormone receptor positive. I think with DB-06, we have a lot of people in the community who are so ready to jump to T-DXd after CDK4/6 inhibitor without considering continuing the anti-estrogen approach. What do you think about that?
I think that's really dangerous. I understand the temptation.
Yeah.
Trastuzumab Deruxtecan is a fantastic drug. It's giving our patients great benefit. But we really need to exhaust our endocrine therapies before we move to a drug like Trastuzumab Deruxtecan. So I'm not giving it after first-line CDK unless that patient did really poorly on CDK. And I'm saying they're endocrine resistant now. Less than 6 months.
Okay.
But if they didn't, then I think they deserve a shot at another endocrine therapy. In some ways, I think what's driving that is a little bit of lack of enthusiasm of our endocrine agents post-CDK and how to predict who's going to respond to a second endocrine therapy, whether that's a post-monarch CDK, whether that's a PI3 or AKT, whether that's a variety of things, an oral SERD, et cetera. We don't have a great way of predicting who's still endocrine sensitive and who isn't, right? Yeah. But, at least from the phase 1 unit, I've treated a lot of patients with oral SERDs, and some patients do really well for a long time. And so to think about that quality of life issue, I think you're essentially trying for that chance that the patient may have a year or 2 years without needing to move on to chemotherapy-like drugs.
Yeah, and, maybe the reason they're progressing without getting their 2 years, which we expect, is because they've developed this resistant, a PI3 kinase, so give them the option of the combination. But now we have combination based on Avera, for example, trial, where we have combination that is not necessarily targeted approach, although you can say Afinitor is really mTOR target, or the EMBER-3, CDK4/6, and another oral SERD. I do think we have to continue down that anti-hormonal therapy approach. And there's always a tail in those patient population. So if you move on too early, you're doing those patients a disservice, I think. Totally.
I think so. I think the reasonable compromise there is on your next line of endocrine therapy to make sure that you're doing a pretty close scan to catch those quick progressors. But I don't think skipping on to ADCs without trying further endocrine therapy if your patient looks like they may be endocrine sensitive is wise.
And the toxicity, although there are some of those orals that the toxicity profile can be a little bit high, but overall they're much better than moving over to the IV options. So we're going to go back to the early setting. Okay. DB11, T-DXd, taxane, Perjeta, Herceptin in the neoadjuvant setting, or T-DXd in the high-risk residual disease setting. ILD and other toxicities are going to be very important for that patient population because that is a population you could cure. And so we have a lower threshold for death. Any risk or even debilitating toxicities. How are you going to manage those toxicities, or how are you going to follow those patients to make sure that you address them when they happen early?
Yeah, so in DB11, there were mandatory CT scans, and they were every 6 weeks, so every 2 cycles. And, that was, there were the 2 arms. They got the arm that got 4 and the arm that got 8. And so you were really doing a couple CT scans for that arm that got 8. Now, that one's not moving forward.
Which we don't do in early breast cancer.
We do not do CT scans in early breast cancer. I was really impressed by the DB11 data of the 5% ILD rate and no fatal cases. So I'm kind of intrigued to actually see what comes in the label of that, whether there are scans recommended or not. Because if we move forward with that 4 cycles, really it's 1 scan. It would be 1 scan at the midpoint, right? The 2 cycles in, and then they're kind of coming off anyway, right? Yeah. So I don't know. I haven't completely decided about that.
I mean, you could do it based on symptoms. That would be 2.
But I think that's always been the advantage of Trastuzumab Deruxtecan, is that you're really trying to do the CT scans to find it before anybody has symptoms, right?
Right, and that way you can potentially, at least from the metastatic data, you can potentially re-challenge if it's a grade 1.
Yeah. Would you re-challenge somebody in
the early setting?
setting?
I would be for the 4 cycles. It's 4 cycles.
Yeah.
Maybe.
Okay.
Because if we can get it to resolve, so you incidentally found it, it's grade 1, treated or not treated, it resolve. Depending on the burden of disease.
I treat them all.
You treat them all with steroids, correct?
Yeah.
I treat them all too. And because they respond faster too.
And plus I want to get rid of it so we can get back on treatment.
Yeah. And so I would consider it, because then you have to switch to the other regimen. Because what are you going to do then? If you only give them 2 T-DXd and now they have grade 1, grade 2 ILD. Well, grade 2 ILD, there's no...
Go back to TCHP and then do DB05 on the back end if they didn't get a PCR?
Do you do 6 of TCHP? Or
We're
do you
completely out of the data-free zone now.
I know, but that's what's going to happen in reality. Does the T-DXd count for 1 or 2 of the cycles of TCHP?
I would do 6.
I would just do 6.
Because we're doing 8 cycles of something in the other regimen, right?
Yeah, I would probably just do 6.
Yeah.
Well, yeah, and then you wouldn't have to do the Taxol, Perjeta, Herceptin. So then, if the patient, so DB05 now, in the adjuvant setting, are we doing, because this is longer treatment of T-DXd, are you then doing Q6-week scans, or are you going to depend on the FDA to guide you?
I mean, I think we should take a little bit closer look at what we really saw there in terms of ILD. I think we are going to have to do scans for sure. And that's because the rate was over 10% and there were fatal cases. And so we need to be looking for those. So yeah, we're going to be scanning. I think it's just an issue of how often.
That supports your DB11
I know.
preference.
I know. Sometimes there's a method to my madness.
Sometimes there's a method. And so neuropathy, hair loss. With T-DXd, there's the risk of alopecia for some patients. In the adjuvant setting as compared to TDM1, which doesn't have alopecia, does that sway you left or right?
I think in the adjuvant setting it doesn't, because all of our patients have had alopecia to AC, THP, or TCHP, right? So alopecia at that point with residual disease when they've already lost their hair is really not a big issue.
But you're continuing it for another into a year.
Oh, I don't know. Once patients have lost their hair, it's normally not as big of a barrier there. It's the having to lose your hair when you have a full head of hair.
So let's talk about the ER-positive patients now.
Okay.
Are you doing anti-hormonal therapy with T-DXd with residual or without? Well, if you're doing T-DXd, they have residual disease. Yeah. So are you doing anti-hormonal therapy with T-DXd?
Yes.
In the adjuvant setting, yes.
And that's what we did in Catherine. That's consistent.
We have Monarch E.
Yes.
And Natalie.
Yes.
Are you doing any of these CDK4/6 inhibitors? We do need a strong statement there.
In the adjuvant setting?
In the adjuvant.
For HER2 positive?
For HER2 positive, yeah, we do need a strong statement. No, thank you. Thank you.
To make sure I had the question right, I'm like, that's
All
not
right,
that's not a valid question.
Just make
No.
sure that
The answer
we
is
say
no.
no. All right, good.